Thank you. And good evening to all. And thank you, Dr. B.K. Mishra sir and Dr. Akhil and MSD for providing me the opportunity. It's okay. So once again, Shipak Rayat. इससे है उससे है नहीं शायद. हेलो हेलो. ओके. So thank you, Dr. V.K. Mishra sir, Dr. Akhil Kapoor sir, and here MSD for providing me the opportunity to talk about this management of metastatic renal cell cancers with immunotherapy. As in the last few hours we are seeing that how many treatments we are discussing in the urothelial malignancies, and obviously the immunotherapy has shown its benefit in over all the things like in your bladder cancer, in your kidney cancer. So this is now the era of immunotherapy, I will say. And in next few minutes, we will see there how this part of immunotherapy or this immunotherapy has created a difference in the management of renal cell carcinoma. One thing, irony is that obviously immunotherapy has proven its role, but how many patients are able to use it and how many patients can use it and how many institutes can provide to the patient efficiently is still a question. So my flow of discussion would be first little bit about the epidemiology of RCC and stages of renal cell carcinoma, then guidelines for the treatment, what we are following, and then later on, what are the current treatment options for the renal cell carcinomas, and what are the immunotherapies and its combinations available we have, and later on, the important trial study that is a keynote 426, that is pembrolizumab plus axitinib versus sunitinib as a first-line therapy for advanced cell RCC, and the 5-year overall survival data has been presented this year. So, and later on a small case study just for a reference. So, coming to epidemiology, we all know that it arises from the proximal renal tubular epithelium and the most common type of kidney cancer in adults and occur most often in men aged 50 to 70. And about 9 out of 10 kidney cancers are renal cell carcinomas. And clear cell RCC is the most common form of RCC and accounts for approximately 7 out of 10 RCC cases. So if you divide the classification, if you see that how RCC has been classified, so it's basis on the cytoplasmic features we know as with the clear cell versus chromophobe RCCs, with the architectural structures like in papillary RCCs, with the anatomic locations, that is collecting duct carcinoma or renal medullary carcinoma, with a specific disease background that is associated with cystic disease, molecular alterations, and familial predisposition. We do see these familial predisposition cases of renal cell carcinoma in our practice, that is hereditary leiomyomatosis associated RCCs. And if you see the papillary RCCs, typically they are 15 to 20% of the all cases. And if you talk about the most common, these are the clear cell, that is 75%. And they have a very distinguished pathological features in the histopathology. So if you then we have to see the global burden of renal cell carcinoma, and this is what the Globacan 2020 data, most updated data we have, and it has shown the total incidence of approximately 4.5 lakh cases and per year, and deaths of approximately 1.79, so like 1,80,000 deaths, and most commonly it is common in males, twice common in males compared to the females, and total mortality is the 1.8 per 1 lakh population. If you talk about the incidence and 5-year prevalence and mortality about the global distribution, there you can see the two parts, that is Asia and Europe has the most common incidence, most common 5-year prevalence, and the mortality is also obviously more in those areas. So it's mainly found in Asia and Europe, and followed by the North America and other part of the world. The most common causes, if you ask me that what are the risk factors that are associated with renal carcinoma, very well illustrated here, that If you start from the top, increased frequency of smoking, obesity, high blood pressure, family history of RCC, obviously 2 times more common in men than women, and genetic diseases that are VHL diseases, hereditary papillary RCCs, Bitt-Hogg-Dog syndrome, and Cowden syndromes. They are all syndromes that are associated with RCC. So prevalence of RCC and available statistics already discussed. Most common RCC is the clear cell carcinoma, and it is 70 to 80% of the RCC cases. Now, after discussing the epidemiology, pathology, and distribution, all we are coming to the stages of renal cell carcinoma. We are well aware that is stage 1, stage 2, 3, 4, and obviously the 5-year survival rate in stage 1, that is 90%, but in stage 4, it is only 5%. So we are focusing on stage 4, that how the treatment has been evolved and now what is the paradigm right now. So if you ask me about how the prognosis is, prognosis depends upon the stage of histology of the cell type. So papillary RCC has a 5-year survival rate of 90%, whereas clear cell RCC, it has a 5-year survival rate of 70%. So better histology, that is papillary, is well responded, as a good prognosis. And the same TNM staging has been shown that if there is a node N1 that is metastatic involvement of regional lymph node, if it is a distant node, it is also a metastatic disease. So this is an important classification where we decide our patients about according to the risk stratification, that which treatment should be beneficial for those patients. So it has been divided into majorly 2, that is favorable risk and poor and intermediate risk has been put together. And there is a criteria for this. This is IMDC criteria or MSKCC prognostic index, how we decide the risk stratification for the patients. And you clearly see in the tables how the preferred regimens has been elaborated according to the risk stratification. And obviously, initially, when we are talking 5 years back, this chart included only one drug, that is TKIs, and all about TKIs. But now in recent 2-3 years, now the TKI has add on these immunotherapy. With every column you have a combination. They are the preferred regimens. However, other recommended regimens, single immunotherapies or single TKIs are also approved. So we have these treatment options for our RCC patients who are metastatic. So here one thing more mentioned, that how the immuno-oncology therapy history tells, we can decide the treatment sometimes in second line as per the treatment history also. So if a patient has a prior IO therapy, obviously there is no further data or anything else that we can support or re-challenge with the immuno-oncology agents. We have to take on your VEGF, that is your TKIs. And obviously, sometimes in real adverse situations where we have left off all of options, we have a child drug like bevacizumab and temsirolimus and all other these things. Sometimes dual IO has true role in small benefits in terms of PFS or OS. So if you ask me that a non-clear cell histology, that is tougher. Obviously, they are the less commoner, but here the data for immunotherapy is not clear. And you can see that the preferred regimens is the clinical trial and the drugs, that is TKI. Here, the immunotherapies are not the preferred regimens, and they have been put in the other recommended regimens and in certain circumstances. So we are now talking that how these immunotherapies has been, you can see the red mark, red box, that how pembrolizumab and axitinib has been approved by FDA in 2019 in the first line setting with the data from the Keynote 426 trial. And the Nivo EP in 2018 with checkmate 2 and 4. So it's good for the patients as well as our institute, that we have a lot of options for treating our patients. And how we should decide now, question is, we should decide that which patients can take which drug and other logistics according to that every option is good, and we should choose by sitting with the patient and discussion and everything. So I'm now talking about the combination therapy. This is a historical, you can say, chronological order at how the things has evolved. And it was initially before the 2000, there was an era of interferon, and where interferon were used to treat the RCCs and metastatic RCCs. And gradually immunotherapy evolved, and a lot of immunotherapy came into picture, and PD-1 as well as PD-L1 inhibitors, as well as the immunotherapy with VEGF combinations, all have gone. And the goal was initially very clear, that initially the targeted therapies has shown the efficacy, but they were not very promising in terms of overall survival and other benefits. However, when the immunotherapy era is the picture of immunotherapy, they improved the response rate, they improved the remission rate, and they also enhanced the patient survival. So this was a good actually a very beneficial event that happened for the management of RCC patients with the with the immunotherapies. So different immunotherapy studies in the treatment of different RCC, I already discussed that these are the interferons, anti-PD-L1, PD-L1, CTLA4 combinations. These are all the combination therapies now approved for these RCC patients. We are all well aware of this mechanism, very important. This mechanism has received Nobel Prize in 2018 or 19, I don't remember specifically, but this diagram, that is a it was first initially started in 1992 and got Nobel Prize in 2019 because of the how the immunotherapy works. So we are all well aware of this fact. So now coming to talking about a lot of immunotherapy, we have to talk about these TKIs, that axitinib, because it has been combined with your immunotherapy. So how axitinib works, it should also be very important to know that it's a second generation targeted drug and it's a potent and highly selective VEGF inhibitors, that is tyrosine kinase 1, 2, and 3. It competitively binds to the intracellular ATP site domain of the VEGFR, and it advantages over other TKIs. It's a potent, it is and little of VEGFR targeted effect, means side effects are little bit lower, and individualized prescription based on clinical dose titration. And the rationale for the combination of VEGF and pembrolizumab is that angiogenesis inhibition can increase T cell infiltration and enhance anti-tumor activity by decreasing the effect of macrophages and MDCs. So overall combination anti-VEGF therapy with immunotherapy is an important strategy for improving survival in patients with RCC. It has been proven with all in the preclinical studies as well as in clinical studies as well as in randomized controlled trials also. So the combination of this Keytruda pembrolizumab in combination with axitinib is indicated for the first line treatment of advanced RCC, and the dose is very clear, infusion of only 30 minutes, that is to be given every 3 weeks. We are well aware of this. And now coming to the trial schema, if you see that how the trial has been designed, it was a well randomized controlled trial where the two arms were there and where the Keytruda was pembrolizumab 200 milligram given every 3 weeks up to 35 cycles plus axitinib 5 milligram orally twice daily, versus control arm was the sunitinib arm, that is 50 milligram orally. And the endpoints were the PFS and OS. So if you see this, baseline characteristics are well matched between the pembrolizumab plus axitinib versus sunitinib arm. And one thing important to note is here the sarcomatoid features that has also well matched in the both arms. So the good amount of, you can say the good number of patients who are having a sarcomatoid features in the histopathology was also included in this trial, because these are the histopathology that are challenges that are very challenging to treat in the real world, because they do not respond sometimes to your TKIs and other drugs where the immunotherapy has just proven this role. So if you see this Kaplan-Meier curve, that how the risk of death was 47% lower in the pembrolizumab axitinib group than in the sunitinib group, and the hazard ratio as it is 0.53 with a significant p-value. So definitely it has proven superior to the single TKI, that is sunitinib. The combination here wins the race. And in the forest plot, if you see that every subgroup has shown benefit in the pembrolizumab plus axitinib arm compared to the sunitinib. And with respect to OS, it has been observed in all the subgroups, including all the IMDC risk and PD-L1 expression categories. So here also, it has been seen in the terms of PFS in the intent to treat analysis with the hazard ratio of approximately, that is, it is 31% lower. So hazard ratio of 0.69, where this proven superior with comparison to the sunitinib. And the subgroup analysis of the PFS also favored the combination compared to the sunitinib. So now this is the 5-year analysis. Now the data has also matured. Initially it has started, but now after the 5-year OS data, we are more confident and we are more data and we are more aware of the side effects, how many patients have left out of the study because of the side effects, or we are not able to complete the data. So this is the right time to check that whether this combination is actually helping our patients or not. So definitely it has proven that. And if you see the Kaplan-Meier curve is still after that, the hazard ratio of 0.69 is clearly even after 5 years. So definitely it is better, having a better profile and better survival compared to the TKIs. So if you see this all, now you can see that up to 12% patient of CR also, like complete response in the metastatic setting. And if you see that PR is up to 50% and overall response rate leads to 60%. So this is also the Kaplan-Meier curve, and it's showing that this is a pembrolizumab plus exitinib is doing better. So do we have 5 minutes more, sir? Okay, thank you. So here, even after the 5 years, the hazard ratio is 0.84. This is important because as initially the hazard ratio is sometimes better in the initial years, but as the survival goes long and the data gets mature, the hazard ratio goes down. So here the 0.84 is the important one. So if you see that favorable risk, the OS is there, but with a hazard ratio of 1.2. So that's how this is not a, you can say, numerically benefit, but in the PFS terms, the hazard ratio is 0.76. So coming to important thing, because everyone has a concern of side effects during the treatment, and definitely it is challenging for the medical oncologist or the treating oncologist that how should we deal with the side effects and adverse effects when we are treating with the combination drug. So if you see this, this is the discontinued treatment out of all the patients were 381. That is 88% had discontinued. But why they discontinued? Because of the progression of the disease, because of some other concerns, or because of the toxicity. It has been explained in the later on. So if you see that in characteristics of patients who completed the 35, and the good thing is that most of the patients, like if you see that how many patients have completed 35 cycles, like 2 years of Keytruda plus your exitinib. So there is enough good number if you see, and they have an overall response rate number is, you see that 102 patients, they have overall response rate and it was evaluated. So enough number of patients have completed the 35 cycles, and that is a good data also and mature data. So if you see that OS benefit, who has completed 35 cycle, definitely showing benefit. And even in the after the 5 years, 32 to 33% patients are still living. So definitely it's all time, every point is in the favor of pembrolizumab plus exitinib compared to the sunitinib. And this is important that discontinuation of any drug because of a treatment related evidence, it is 33%. Like out of 1/3 patients, we have in the trial has discontinued the drug because of the side effects. And really in the real world study, we do face sometimes those side effects that we have to stop the treatment, or we have to switch the one treatment to other, or we have sometimes to stop one part of the treatment and continue other. So it's not more than 1/3 patients who have discontinued because of the treatment related. Other discontinuation causes are very clear. Grade 3-5 side effects do happens in 67% of the patients, and overall side effects have happened in 96. So every patient may have some sort of side effects, but mostly the treatment discontinuation happens only in the 1/3 of the patients only. So finally, summary is that Keynote 426 represents the longest follow-up up to the date of combination of checkpoint inhibitors plus a VEGFR TKI, and for the first line clear cell RCC, and pembrolizumab plus exitinib continued to demonstrate improved overall survival, PFS, and overall response rate versus sunitinib for patients with previously untreated clear cell RCCs. A substantial percentage of patients completed 35 cycles of pembrolizumab with good long-term outcomes, and these data continue to support pembrolizumab plus exitinib as a standard of care for patients with previously untreated advanced clear cell RCC. So very small case, just 2 pages, and this is a Mr. Prakash, who is 67-year-old male, presented in the hospital with abdominal pain. Investigations were done, so it was come out to be like intermediate risk clear cell RCC, which is showing a lung mass, that is lung metastasis in the CT. There was no PET scan done. Baseline ancillary investigations were done. All was normal within limits. And the pathological diagnosis was clear cell RCC, M1 disease. And he was started on the pembrolizumab plus exitinib, 10 milligram per day, means 5 milligram at 12 hours. After 6, this case just only showed for the side effects purpose. And after 6 cycles, patient complains of abdominal pain, and laboratory investigations have shown completely normal. But it was suspected that because of this low TSS, that is hyperthyroidism, is presumably the cause of abdominal pain. But the patient was continued on the immunotherapy. But after 10 cycles, the patient began exhibiting the following adverse events like rash, mucosal inflammation, diarrhea, and decreased appetite. Then the suspicion came. So my point is, whenever the patient is on immunotherapy or TKI, every signs and symptoms should be seen with suspicion. Otherwise, you will miss the things, and sometimes it may create a much hazard or more fatal things also. So if pain of abdominal cause, maybe because of anything else. So later on, someone has sorted and they suspected that it may be a hepatitis also, because minor SGOT-PT was raised. and they later on did a biopsy, and it was found that it is a immune therapy induced hepatitis. Later on, patient both the drugs has been stopped, and patient was started on steroid and gradually it's improved. So this is the only slide, and everyone in the hall may have used immunotherapies, and they may see a different type of side effects. Even the incidence which is lower also. Sometimes I see nephritis, sometimes I see hyperglycemia, sometimes I see a rare skin effects that when every time you use the immunotherapy, there are full rashes body, full white patches body. Once you stop it, after 3 weeks, sometimes it goes down, sometimes it flare up. So that's how learning happens, and gradually we are much used to for the immunotherapies. And it's a good thing that we have a major important thing for the patients of RCC. And with this, I thanks to all for kind listening, and any question will be welcome. Thank you.
Questions can be sorted out afterwards. Now I would like to invite Dr.